Hi everyone. This is Dr. Sameer Chaudhary, and I'll be talking about optic neuritis, which is the most common cause of optic nerve dysfunction in young adults. So, as the name suggests, optic neuritis is the inflammation of optic nerve. The causes are highly varied and have been classified as demyelinating, infectious, and other inflammatory and autoimmune etiologies. Among these, demyelinating causes are the most common and include idiopathic or isolated, where there is no known systemic demyelinating disorder. Multiple sclerosis, which is the most common systemic association. NMOSD, which is neuromyelitis optica spectrum disorder, and myelin oligodendrocyte antibody disease. So, how does a typical case of optic neuritis present? It is basically a young female in the age of 20 to 50 years who presents with sudden, painful, unilateral loss of vision. The patient might tell that the blurring is more prominent centrally, and when we examine the patient, the visual acuity is usually dropped between 618 to 660. RAPD is almost always present, and when we examine the fundus, in two-thirds of the cases, the fundus is usually normal, which is suggestive of retrobulbar neuritis. In few cases, disc edema might be present, which signifies papillitis, and in other few cases, in addition to the disc edema, macular fan or macular star might be present, which signifies neuroretinitis and is suggestive of MOGAD or other infectious etiologies. When we evaluate central fields, central scotoma is the most common field defect that we see, and other field defects includes paracentral scotoma, centrocecal scotoma, and altitudinal defects. Color vision is grossly impaired and usually doesn't correlate with the visual acuity. So this is an HFA of a patient with optic neuritis, which shows paracentral scotoma in the pattern deviation, and the mean deviation shows minus 4.62 decibel, which is suggestive of generalized depression. So basically, the papillomacular bundle is predominantly afflicted in the optic neuritis, which explains the predominance of the central symptoms and signs. So the diagnosis is essentially clinical and is confirmed by neuroimaging, and MRI remains the investigation neuroimaging of the choice. Stir and flare sequences are preferred as they delineate the lesions much better. Gadolinium enhancement should be requested, and thin slices of 1 to 3 mm should be requested. So contrast enhancement of the optic nerve is highly specific and helps us differentiate it from non-inflammatory in optic neuropathy such as NAION. So this is the MRI images of two patients with optic neuritis. Here we can see optic nerve thickening and enhancement bilaterally, whereas in this image, the same is seen unilaterally. So the ancillary investigation should be ordered when the presentation is highly atypical and other etiologies are suspected. So serology such as aquaporin 4 IgG and myelin oligodendrocyte IgG can be ordered and should be tested, preferably using cell-based assays over immunofluorescence cytometry or ELISAs. CSF analysis might reveal oligoclonal bands in multiple sclerosis. So coming to the MRI features, NMS typically, the location of lesion along the optic nerve is typically unilateral and anterior optic nerve is predominantly affected. Whereas NMOSD and MOGAD can be both, are more commonly bilateral. NMOSD typically affects the posterior segments more commonly, the chiasma and the optic tract, whereas MOGAD can affect all segments, although anterior more common. The optic neuritis in NMOSD and MOGAD is typically longitudinally extensive. By that, we mean that more than 50% of the prechiasmal length of the optic nerve is affected. So the treatment is as suggested by the ONTT trial. Steroids are the first line treatment. IV methyl prednisolone 1 gram per day for 3 days, followed by oral prednisolone 1 mg per kg per day for 11 days, followed by weekly tapering. This is the pulse regimen. We should rule out active infections and monitor the blood glucose and the blood pressure of these patients. This accelerates recovery and delays conversion to MS. However, ONTT also revealed that when they compared steroid versus placebo at 1 year, the visual acuity was similar. However, contrast sensitivity, color vision, and the visual field sensitivity was better in the steroid group. Oral steroid should not be used alone as it doubles the risk of recurrence. Multiple sclerosis might be managed with interferons and immunomodulators. Recurrent steroid refractory cases, steroidy should be ordered. We should rule out systemic inflammatory disorders such as sarcoid and SLE. An MRI spine should also be ordered. NMOSD and MOGAD are more likely to be steroid refractory and recurrent. Plasmapheresis, intravenous immunoglobulin might be helpful, and steroid sparing agents such as azathioprine, mycophenolate mofetil, and methotrexate might be required. Rituximab is now very widely used. It is a monoclonal antibody against CD20. So these are the references which I suggest for further reading. And once again, I thank YOSI for this lovely opportunity. Thank you.